Well, welcome again to this next session of our National Day of Compassion. Um, the event that we're planning is a collaboration between the Charter for Compassion here in Australia and the Global Compassion Coalition. And our theme this year is Compassion in Action. But I'm delighted this session to be able to introduce you to Professor Samar Aoun, who is the lead of compassionate communities in Australia. Terrific to have you with us, Professor Aoun. Thank you.
Thank you, Terry. Thanks for the invitation.
Yeah, let me. I was just looking back over your bio, and it's really quite impressive. And I just want to refer a little bit to it. You are the research professor with the Perrin Institute in the University of Western Australia in terms of palliative care. You've been a real champion for palliative care and a public health approach to palliative care and grief support, and mainly through your animation of community networks, including the Compassionate Community Network. You've been very involved in end-of-life care, including for some underserved groups such as the motor neurone disease and dementia communities, and people that live alone. And of course, with the Charter for Compassion, they have a special place in our concern and the particular suffering that those people experience. In a voluntary capacity, Professor Aoun is the co-founder and chair of the Southwest Compassionate Communities Network in Western Australia, and more recently the founder and chair of the Compassionate Communities Australia Network, the conference of which we attended together last week, which is terrific. You also have been president of MND Australia and MND Association of Western Australia. At an international level, you're on the board of the Public Health Palliative Care International and European Association for Palliative Care. And several years ago, you received a member of the Order of Australia as the Western Australian of the Year. That's quite a story. Where did it all start for you, Samar?
Well, it all started, Terry, when I was invited as a researcher to join a group that are doing palliative care research.
Hmm.
And I have a strong focus on outcomes.
Yes, of course.
And I guess the actual discipline really grabbed me at my heart because in palliative care, the definition is not just about clinical care or symptom management. It's about the psychosocial, spiritual, existential, family care support, bereavement support.
Mm.
So that really sort of spoke to me, really resonated with me. But I kind of noticed that all these other aspects of palliative care are really ad hoc. Most of the funding and the focus is on clinical care, and the clinical community, which is super important. But I was sort of wondering who's doing the rest of it, it needs to be tackled. And of course, some of the work I've done in bereavement support in terms of asking the Australian community who really supports you when you are grieving. And it was the first empirical evidence that we've had that compassionate communities are alive, like people are relying a lot on their families, friends, neighbors, their priests, the faith organizations. But it's all going unnoticed because previous research was just about those who have had really complicated grief that actually are in touch with services, mental health professionals. So we never really knew what happens to the average person who is bereaved, have got normal grief, and how do they deal with this?
Yes.
So I guess that was a groundbreaking research, although really very common sense. But it sort of changed the landscape from pathologizing grief to making it part of life. All of us are going to go through it. And more than once, so that was really something that grabbed the attention of the international community who were working in public health palliative care, unbeknown to me.
Yes.
This is what I shared with them, basically. And so then I got introduced to the concept of compassionate communities. And I thought, well, here we go. We need more evidence that
Hmm.
it works.
Yes.
So from that bereavement survey, we went on to looking at compassionate communities, and there was a real dearth of evidence behind it.
Hmm.
And there was no way of convincing policymakers or funders
Hmm.
to fund anything when we say compassionate communities, because there was no research evidence behind it.
Mm.
So that was really my main aim after this, is to show that if we have the community working together with palliative care services and other health services, what kind of results can we get? And this is what the Compassionate Connectors program was about,
Hmm.
whereby when we started our Southwest network in the southwest of Western Australia, we partnered with our local service to actually test that model of care. And it was really very rewarding to be part of that project, not because of just the warmth and love that and social connectedness that we were able to create in the community, which had improved significantly because we had all these standard tools that we had applied before the program and after the program, what changes we've made.
Mm.
But then again, when we did the cost effectiveness analysis, it showed that again, those people who have had the compassionate connectors around them, and and also the compassionate connectors called in for more caring helpers from the community
Hmm.
to be able to look after the social and practical support of those families in need. They were all, of course, in the under palliative care, and terminally ill. So we found out that we've reduced their hospital admissions, we've reduced their length of stay, we've reduced their ED presentations, and we doubled the amount of outpatient services. And the reason being is that, if you have somebody with COPD and anxious over the weekend, they can't breathe, they used to admit themselves to hospital if they
Yeah.
were alone. And half of the patients referred to us from the service were home alone, which is
Hmm.
very sad.
Yes, it is.
And so now that we had the compassionate connectors building the capacity
Hmm.
of the community, and bringing those circles of care around those families in need, so this patient would call somebody from the community to be with them, and so they can wait till Monday and go to outpatient rather than occupy a hospital bed for no good reason. And even if they had to go to hospital for some other problem, they didn't want to stay longer than needed,
Mm.
because they've got people who love them in the community now,
Yes.
and they want to get out. While before, if you're lonely, you just extend your stay in the hospital
Mm.
because you have no one to look after you in the community.
Yes. Yes.
So we doubled the amount of outpatients visit, because it's again those lovely connectors and the caring helpers in the communities that became part of the networks of these people, would make the appointment for them
Hmm.
and transport them there, because again those two activities are really difficult for people who are disabled towards the end of life, to
Yes.
sit forever on the phone to be able to make an appointment or to find somebody to take them.
Mm.
So it all makes sense when you look at the bigger picture why all this has happened.
Yes.
And to top it all, we saved $500,000 in 6 months for the health service. So now it's just a matter of the health service knowing how to claw these savings, which, as you know, health departments are very complicated the way things are happening. But anyway, we're still advocating. I know that the program had been taken up in areas in Europe and the USA, so it's sort of was very much embraced by the international community. And again, it's going to take different forms, whatever, depending on your situation, the cultural situation, the health service situation.
Mm.
So that's been really an eye opener
Yes.
when we bring the community to be part of delivering that care. Look at all the benefits.
Yes. Yes. And you said that about 50% of the people referred to the program were living on their own.
Mm.
So social isolation is a really big issue in our country at the moment. Um, but these are only the people that were referred to the service who require palliative care. So
Exactly.
there's an enormous cohort of people beyond that. Where do the connectors fit in terms of training other and gathering other volunteers in the community? What's the role of the connector?
So the connectors are about enlarging the networks of support
Yes.
around those families or the lonely person, I suppose, as well.
Mm.
They are people with lived experience. So we kind of promoted this role in our community. And of course, it helps because we did it in a rather kind of a small rural area, right, with the
Yes.
regional center.
Yes.
And then we've had the first 20. They were amazing. They knew exactly what's needed because they've helped other people with a life-limiting illness.
Mm.
They were there during the death. So we had a one-day training program for them
Mm-hmm.
in terms of, again, and that was shared by the health service because the health service had their own kind of guidelines,
Mm.
all that stuff, for volunteers.
Of course.
But we always call them activated citizens. They're not really volunteers in that, like sort of the old-fashioned service of volunteering, because they don't really report to a health service or us even as a research team.
Mm.
What
Yeah.
we did, we just connected with them on a 2 weekly basis just to hear what they are doing in people's home. So
Mm.
they had a lot of agency and autonomy, how you do it in normal life. We wanted to make the program as organic as possible because it needs to be sustainable and it
Mm.
needs to be, everybody can take it up. So
Mm.
we didn't want to have all these restrictions around it. But we know when you work with health services, there are a lot of restrictions. So we kind of managed all that as as we went along. And
I love the
so,
fact that your research and that was really focused on outcomes, not just getting a published paper, but you actually wanted to see the difference that it's made on the ground. And very clearly, the compassionate communities has done that by animating, training, mobilizing networks, giving isolated people support, and saving the health service.
I know, I know. See, when you've got the right moral compass while you're doing this stuff, it all like lines up very nicely, which is, we were really very pleased with the results. And of course, as researchers, you have to publish in those, peer-reviewed journals because that's the only way the international community would hear about it as well. So
Yeah.
we did like small reports, whatever, to get to the community to understand that, as well as the professional journals as well.
Mm. So
And
you said
those
it was in a
connected.
small community. Sorry, it was in a small community. Does the same model work in a bigger community where people are more kind of fragmented, do you think?
Yeah, so this is what we are trialing now.
Okay.
Um, so in that sort of smaller community, the connectors knew their communities well, and they knew where the resources are in the communities, and they
Yes.
were able to actually tap into this. I mean, we did create a directory for them as
Mm.
well.
Mm.
But then they were so resourceful, they could find exactly where the help can come from.
Mm.
For a larger area, what we are trialing now is a model with local government.
Mm-hmm.
So, as you mentioned, the year I was the 2023 WA Australian of the Year, I had few invitations from local government.
Yes.
And, you'd have like the community come, and they were all very interested in the program.
Yes.
But they just needed to know how to start. But we didn't have local government who knew what to do, or they were at a stage where they're able to embark in this.
Mm.
So through now this project we're doing this year, we're able to hold their hands more and see how they can basically involve their communities and create a connector program.
Mm-hmm.
Because I think that's the way to do it in metropolitan areas. When you think how you're going to divide it, it's
Mm.
like quite a large group. But I noticed that, say, where I live in Perth, so the people within my city, suburb, they know exactly where things are, what are the programs, the aging programs, all that stuff.
Mm-hmm.
So it'd be very interesting to sort of start trialing this,
Mm.
and see how it goes in sort of metropolitan areas,
Mm.
really.
So, as I understand it, the local governments would say this is something that we value. Their community development department or something like that would be trained and take it on, and then they would look to identify people that could be trained as community connectors within the community.
That's the idea. Yeah,
Okay. Yep.
yeah,
Yep.
yeah.
Okay. And with the community connectors that are trained, what do they do if there's nobody that they're caring for?
Um, okay, so it just depends who we're going to partner for referrals. When
Yes.
we worked with the health service, we had the referrals kept coming.
Really? Wow. Yeah.
Yeah, because palliative care services and chronic disease services, they know there are gaps in the way they are looking after those patients.
Mm,
They don't have the means to look after the whole, spectrum of
mm,
needs.
mm,
Clinical, great. After this, it's so ad hoc.
mm,
And so they realized how much this program had actually benefited their patients.
mhm,
And we know from the research, again, that we've done in compassionate communities that 95% of the care is done in the community by community people,
mm,
the neighbors, the schools, the sporting clubs, the civic
mm,
organizations that we live
mm,
through. Only 5% of the care is clinical.
mm,
So that was quite well understood and felt.
mm,
And so we really need for health services to kind of start integrated this in their practice.
mhm,
If we can get over the paranoia about risk management and all that stuff. So that's the kind of body of work that we really need to do.
mm, mm, mm,
Now, in local government, so we have one local government who is partnering with a hospice.
mhm,
The hospice are really interested to work with them and refer to them.
mhm.
And so we'll work our way through and see where, we could have community referring. It doesn't have to be people who basically are towards the end of life. So it can take several models depending on the community and the cultural aspects, that we're working with. We're working also with multicultural groups. So again, it's different, for each group.
Yes, yes.
So we are at the stage of now, delivering those presentations and information sessions
Mm,
to build up, the interest, and then we'll work case by case how we're going to get the referred people. Yeah.
mm. And we met in Brisbane last week. There was quite a dynamic group of people got together at was it the first Compassionate Communities Forum? Yes,
Mm, mm.
National Forum. And what were some of the highlights for you about that in terms of great stories happening on the ground? Because our focus is around compassion and action, and clearly what's happening in the West is focused on that. But what other stories have you heard in other places?
Well, Terry, what we wanted to do through this forum is to really emphasize that compassionate communities is not just about awareness raising activities. It's
Yes.
about system change and it's about civic action,
Mm, mm,
which, when people are in the midst of doing all these educational programs, and they are so important, we need to keep going, they're not able to focus on what else can compassionate communities deliver. That's why I asked Professor Alan Callagher to talk about this in
yeah,
his speech, to kind of focus everybody. We're here today to look at what are the challenges in every setting
mm,
that we are facing as compassionate communities.
mm,
What is working well? What is not working well with us? I mean, as you can see from my presentation with the health service, I highlighted exactly what we need to do.
yeah,
So what we have asked is sort of key people. I'm sure next time we do it, we'll have other people presenting. So we've had somebody from local government, somebody from workplaces, somebody from hospice, somebody from aged care, to work with us on a advocacy statement, sort of. So what is the issue and the need that you have in that sector or setting?
mhm,
What is the aspiration? What's the best case scenario that we can have in those
mm,
settings? What are the calls to actions? What are we needing to change things or improve things? And who will support us? Who's going to work with us? Because it's all about partnerships. It's about informal and formal networks working together.
mm,
And so, so what happened in the forum is that each presenter finished their presentation with his advocacy statement.
mhm.
And then that advocacy statement, as you know, was then debated a lot more in roundtable discussions. And of course, I'm still working on adding everybody's, more opinion
Just
came, which
last
is
week.
really
Yes,
fantastic,
yes,
because we really wanted those amazing people who attended to feel part of the solution, to
yeah,
sort of be able to go back to their states, settings, and have something in their hand to start using to advocate for a system change.
mm,
because we can't wait any longer. We know that governments in general, it's about, the cycles that there are in government. This is more about, look, we've reached a stage now where we know in the next 20 years, the number of people who are dying is going to double.
yes,
What are we doing about this? We don't have enough hospitals. We don't have enough workforce. And the problem is people are dying in hospitals over 50%.
yes,
The reason being is that our community is not death literate, is not grief literate. They would like to be, but we de-skilled them throughout the decades because we kept telling them health professionals do it better.
mm,
And we have this in Australia, as in probably other Western countries, the reliance on the government from the moment we are born to the moment we are die. We think it's their responsibility.
mm,
Well, not really. It is the community responsibility,
yes,
and this is what they need to understand. If they really want their loved ones to die at home, which we hear all the time, this is
yes,
what people want to die,
mm,
they need to sort of lift up their game and start knowing what to do, in all the areas of death care, and start, thinking of death as a taboo. And we don't need to discuss it. We're encouraging advanced care planning to get those conversations going in the community.
yes,
And it's so important to get the younger people into these conversations,
mm,
because sometimes I feel with the older people we've kind of missed the boat there because they're so entrenched in the way. There'd be maybe the baby boomers people, but the older ones, probably they are more attuned to this because they've seen this happening, grandparents and all that stuff. So it's really intergenerational that we need to get this death literacy and grief literacy happening.
mm, mm. And there's a death literacy index in Australia as well, isn't there, that helps us to see the progress that we're making in helping people talk about death and dying through things like Dying to Know Day and Are You OK Day. There's all sorts of initiatives that help in that space. And when we think about people dying at home, and you talked about the large number of people that are living on their own. Dying at home now may mean an aged care facility.
Right,
It
yes, I
doesn't
know.
necessarily mean in people's own homes. So extending these compassionate services into aged care facilities and other places where people live is an important part of what compassionate communities seek to do.
Certainly. And it's come very clear when we did the evaluation of palliative care in aged care facilities in WA. Um, I mean, there's a lot of programs that are helping with improving palliative care knowledge and practice,
Yes.
amongst the aged care homes professionals. But uh, what is missing, Terry, is that feeling that people belong, feeling that they are treated as a person, not just as a number,
Mm, mm,
feeling that they need to be cared about, not just cared for.
yes.
But unfortunately, this is how they're feeling in those nursing homes. I mean, it promotes ageism, it promotes loneliness, is not letting, the community being part of that. And this is what we need to basically, and that's part of the recommendations that we did. We need to have a compassionate community approach to care in those aged care facilities.
Mm,
We need to have, referral pathways between the home and the other community-based organizations that can help, because say grief starts from the time when this person is admitted to the aged care home.
yes.
The families are feeling grief for letting go of their loved one, but they can't care for them at home. The person that's there is feeling abandoned, by their family. So all these issues are not discussed, are not looked after. And it's a sad situation, to be honest. So we're going to see how we're going to improve this. And I was really impressed with the person who presented in aged care, Erin Fulton, that Bupa Aged Care, they're trying now they've got in their policy like pillar 3,
Mm-hmm.
whereby they're trying to see how to get those compassionate connectors model
Mm,
in aged care facilities. So it'd be very interesting to sort of work with them to see how that would work, probably a model that can be used by other aged care homes.
And a dimension of your work is around bereavement care as well. So one of the challenges I know in the health service and in aged care is when the patient or the resident dies, there's no ongoing care. So one of the things that a compassionate community does and a connector does is it gives that continuity of care as people, face their death, they experience death, and then the bereavement support for families afterwards. And when there's a complicated grief, as you say, there are services in that, but many people experience a more generalized grief several times in their life,
Yeah.
and the support of family and friends and mindful activated citizens, as you say, can be really helpful in that process. In fact, essential.
Yeah, I mean, it's important for them not to feel abandoned after the person dies. I
Mm,
mean, some of the stories that come from the survey is that the nursing home expects them to clear up the room within hours of the person dying.
yes.
Like they're still struggling getting to terms with that, and look, preparing for the funeral and all that stuff, and yet they're under pressure to
Mm,
clear that room because another one. I mean, I know a lot of people are waiting in hospitals now to have a
yes.
bed, and so yeah, the situation can be a lot more humane if we can introduce a
Yes.
compassionate communities model of care. Yeah.
I remember when I was an aged care chaplain, there was that kind of pressure,
Mm.
um, to have the room cleaned, and we would hold a little ritual where we'd have a table outside with a picture of the person that had died, perhaps some ornaments, a candle, and we'd invite residents to come and to share stories about the person who had been in that room, for whom that room had been their home. And then we would go into the room and experience something of the emptiness of the room and some of our feelings of loss and grief. But then we would perhaps have some incense or something like that, and we would start to prepare the room for the next resident and the way that the community of the aged care facility could kind of respond. But the pressure was still there in terms of the timing. And once the family whose resident had died left the facility, there was really often no ongoing care. So having a supportive community to be able to refer to is really, really beautiful. And I know in the hospital palliative care setting, the pressure on the beds is even greater. There's often not, you know, overnight. It's almost like immediately. So
Yeah, I
there's a
mean,
place for people in all of this, isn't there? You as a researcher, clinicians who are mindful of the gaps, but also the particular skills and the ways working together, local government, and ordinary people in the community that want to be activated to help support people at distressing times in their life.
yeah, and certainly we've learned something from the Connector program is that, these ladies, I mean, I have to say they're all ladies, right? I mean, we tried to get men, but we'll keep persevering. um, they they kind of loved being part of a program.
Yes.
They were doing this kind of help anyway in their communities.
Mm.
But because we live in a litigious, litigious, how do you say it? Anyways,
Teachers. Yeah.
legal
Yeah.
stuff. Yeah.
That's right.
And they felt lonely with the way they have been providing that support. So to be part of a community of practice really suited them well. First of all, because they felt supported within each other and by the health service being part of that. So these sort of compassionate connectors program is only a start to bring that confidence and skills back into the community, because eventually we don't need them if
Mm.
every one of us become a connector,
Mm.
in their own communities. So it's just really gathering them together again, and making them feel they are part of a program, a community of practice.
Mm.
So that's kind of the way, I mean, not in my lifetime when we will stop doing compassionate connectors program, but hopefully that's my vision, is that every one of us becomes more death literate and grief literate, because we cannot rely on funding palliative care services for bereavement care. This is never going to happen.
Yes.
And what we did in our research is that we called for them being more aware of what's happening in the community and refer to, to the community, those people, because this is where it's sustainable.
Mm.
Like one of the surveys, the survey responses, one of the, oh no, when I was presenting was again a pastor carer in one of the hospitals. He said to me, um, so, okay, fine. You're saying we should refer, the bereaved people to community-based organizations. And so what if they don't come back? I said, come back where? You're not a GP, just referring to a specialist and expecting them to come back.
Yes.
This is where they belong. This is where, because he said, look, the memorial services he was doing weren't well attended. And
Mm.
I said, okay, what is this telling you, right?
Mm-hmm.
They don't want to come back to the hospice or to have a memorial service. They'd rather connect in the community. And of course, and I said to him, give an example again, it's like through the survey what people have said. We have in Perth a group called Mothers Without Mothers.
Mm-hmm.
So they meet on their mother's birthday, and then all they talk about is about their dead mothers, and it's really great, like it's a homogeneous group of ladies who have lost their mothers, and they are mothers themselves.
Yes.
Well done. So I
Yes.
said, look, for instance, if you have somebody in this situation, make sure you know what's happening in the community in terms of those peer support groups,
Mm.
I don't know, compassionate cafes, death cafes, this is where people need to be connected and they make friends
Mm.
and people in the same situations. And that's how it should be in the community.
And as you say, as people are kind of broken open, this is part of their lived experience. They have the capacity to connect with people at a level of empathy. But if they've kind of worked through the grief, their own grief in a way, and are able to be genuinely there for another, it's a genuine expression of compassion. But there's a reciprocity in that as they give that support to the person suffering, they're also receiving, they're a part of a community and receiving healing themselves. So it's reminding us of the way that compassion has informed and activated communities for centuries, really.
Absolutely. And we've published one of the papers about the connectors' feedback. What was it like for them to be in this program?
Mm.
And invariably, and I think it's in the title, the reward is much greater than the effort. So for them, they were surprised the little things they were able to help families, how much it meant to the families, because really for the families, it normalized the way they are living until they die.
Mm.
But for the connectors, they felt it's really minimal effort they've done, but yet the reward they got personally was
Yes.
great.
Yes.
Yeah.
Yeah, that's the delight of compassion, isn't it? Whereas
Yes.
things like, if we're sympathetic, it doesn't actually kind of cost us very much. It's kind of just an assent or Samar, I'm sorry about what you have, but it doesn't actually cost us anything. If we get lost in our own story, we can get distressed by it and not really able to be there for others. So compassion is a way of connecting deeply with others, but remaining focused on them. And the miracle is that we get back something out of that encounter.
Exactly, exactly. So it's really, I call it empathy in action. That's compassion.
Yes, yes, that's right.
It's a
Yeah,
step
and
up.
that's
Yeah.
absolutely. Yeah,
Mm.
yeah. So we talk about in the Charter for Compassionate, first step is a sort of an understanding of a common humanity. So that's kind of where the lived experience comes in. You know, today I'm a doctor, but tomorrow I might be a patient. That helps us
Mm.
to see
Mm.
that there is a common humanity to us. We're then open to the suffering of others because we've experienced that ourselves. We're willing to offer something to the other. And through that experience, that shared experience, we glean some wisdom that helps us to act, with compassion and with wisdom.
Yeah.
Sarah, it's
Yeah.
been delightful speaking to you. Just to clarify for people that the Compassionate Communities Network is really very focused on public health palliative care, but it's mobilising networks of communities of support that can be there, particularly at the end of life. And one of the best stories about what's happening in compassion in Australia. Samar, your leadership in that, your research and the way that you've been honoured is something that we're very grateful for. Congratulations.
Thank you, Terry. And I was really pleased to see you at the forum because we need people like you to be part. I mean, you're already part of the global compassion communities. But yeah, I mean, compassionate communities, it is one strategy in public health palliative care. It's about how do we get the community involved as an equal partner in delivering that care.
Mm, mm,
And obviously, my work is in palliative care, end of life care. This is where that neatly, like that model fits in with
mm.
this. But it doesn't mean you can't have compassionate communities at every stage of life,
Yes, yes,
for everyone.
absolutely.
But it's just this is what we do at the moment,
Yes,
and
yes.
we focus on that. Yeah,
And I think, that's part of the reason that I'm connected with both, or all three organisations, the Charter for Compassion, Compassionate Communities, and the Global Compassion Coalition, because there's a particular awareness and emphasis and need. We're at this kind of pointy end of life that can actually animate communities and activate them in a way that we would want to become common, with every experience of suffering and every experience of life.
exactly. Yeah, yeah.
Samar, thank you so much for your time. We acknowledge all the work that you're doing, grateful for it, and thank you for being a part of our National Day of Compassion today.
Well, thank you for letting me know. We have a national day for that. So we'll keep an eye on this every year now,
Yes.
because the World Compassionate Communities Day is on the 1st of November.
Yep.
I'm
Well, we can
doing
celebrate
that.
all
Yeah.
of the
So
days,
we
and
can
every day
always
should be a
also do
day of
something
compassion.
then as well. Yeah, perfect.
Terrific. Yeah, love to
Yeah.
do that. Thanks so much,
Okay.
Samar.
Thanks, Terry.
Thank
Okay.
you.
Bye.
Bye for now.